Hi everyone, this is Sherry Bowringer. I'm an Associate Editor for Prescriber's Letter and Pharmacist's Letter. This set of recommendations is about strategies for managing hyperglycemia in adults with type 2 diabetes. And the American Diabetes Association has a new position statement which offers a more patient-centered approach to management of diabetes. And in terms of drug therapy, metformin is still the first-line choice for most patients, but ADA is offering more therapy choices. And here to help us today with these recommendations, we do have a couple individuals active in the ADA, including Dr. Craig Williams and Dr. Ann Peters. And Dr. Peters actually is a contributing author to this new position statement. So Ann and Craig and other panelists, we're delighted to have more choices of drugs to add to metformin, but we're still trying to help clinicians decide which one to add for patients. And kind of the oral choices, sulfonylureas and Actos, they kind of have some downsides. So we're seeing the DPP-4 inhibitors such as Januvia, very popular choices since they're available orally. However, they don't lower A1C as well as sulfonylureas and Actos. So I just wanted to ask you all and get your opinions on adding them to metformin. We're saying save them for patients close to goal. Do you agree with this?
I think they're fourth-line agents.
Fourth line.
Yeah. I mean, their popularity is amazing given how very little efficacy they have, particularly in people close to goal. Now, I can't believe how these drugs have taken off. Ann, I'm interested in your thoughts, too.
Yes, Ann.
Well, so this is the deal. So everybody wants a simple answer for the second step in treatment, and it'd be really wonderful if I could give it, but I can't.
Mm-hmm.
Just try, Ann.
I can't. So what I say is that you've got to individualize this based on the patient. And
okay.
I personally think that for many patients, for instance, if you have a patient and you've decided that your target for them, and remember, this is a patient-centric guideline where we individualize targets. So if I had a guy who was 45 years old, came to see me, his A1C is on metformin still about 6.8, and I want to get him down to below 6.5, a DPP-4 inhibitor makes a lot of sense. But if I have a patient whose A1C is 8 or 9, and I want to get them to target a GLP-1 receptor agonist, second-line therapy makes a lot of sense. But it's expensive, and it's an injection. If I'm in East LA where patients don't have access to medical care, they don't have a lot of money, sulfonylurea agent would be my next choice. So that's why we made all of the steps patient-centric, that we want to look at the patient, their situation, and then assess what they need next. There's no one right answer, and there's no one best therapy, and that's what we wanted to stress, was how, as a clinician, you look at a patient and the setting in which a patient is treated and make choices. So it makes it frustrating if you want actual prescriptive guidelines, and I at first wanted our committee to come up with that, and in the end we decided that you couldn't based on the real world of diabetes treatment.
Yeah, I think one point that comes across well in the document, which is a point well taken, is there's just not the body of comparative literature that you kind of hope we might have for some of these agents at this point, where I think we've all recognized metformin as a first-line agent for quite a while, and it'd be great to have 4 or 5 year trials where you add pioglitazone versus adding sulfonylurea and see what happens. But I think Steve's point is well taken, that there is still some unknowns to some of these newer medicines that we just don't have the same volume of clinical years of experience with them to know if there's anything surprising out there still. But yeah, I agree with the general approach certainly that the committee took, and like these much more than the previous kind of glycemic recommendations from the consensus.
Well, they give more choice, which is nice. And what I'm hearing Ann say, and I think maybe we can make this point more clear in our article, is that basically we need to individualize therapy. So in terms of, back to the question about the DPP-4 inhibitors like Januvia, they seem popular, but you know what? They're really not the best choice for everybody. And I think you gave a terrific example. And, bringing up the fact if you have somebody with A1C or 8 or 9, they're probably not the best choice to go to. And I see we do have lots of audience questions coming in. So, Jill?
Yeah, we have lots. Okay, here's the first one. Years ago, metformin was contraindicated in renal insufficiency. The questioner understands that this has changed, but who now should we avoid metformin in?
I'm sure that came up for Ann. I have an answer. I'll see if I'm sure that came up in discussion at the committee, Ann.
Yes, a lot, because the European guidelines differ from the U.S. guidelines.
This is Steve Nissen. It's been my impression reading the literature that the risk of lactic acidosis has been overstated for metformin, that it's really a very rare side effect, and that probably, particularly in the U.S., we're too conservative in our thinking about when we should not use metformin. That is to say that lots of people with mild renal insufficiency can be treated, particularly if you're willing to use a little bit lower dose.
Yeah, that's a very accurate summary of a lot of literature.
Okay. Yeah. What kind of serum creatinine cutoff should we be looking at?
Well, so we don't look, so in Europe, they don't look at serum creatinines, and they look at eGFR.
Right.
And European guidelines, which I, in my practice, have largely adopted because I think it makes a lot of sense, is if the eGFR is 60 or more, then you don't have to dose reduce. So you use 1 gram twice a day. If it's between 30 and 60, you cut back to half that, so it's 1 gram a day max dose, and if it's less than 30, you don't use it. And that's what they've used quite successfully there, and that's what the European standard is. So it's different from the FDA, which uses a serum creatinine level, but I think the European guidelines make more sense in that instance.
Okay. Jill, one more audience question about sulfonylureas?
Yep, I've got a great classic one here. It's the old adage of sulfonylureas burning out the pancreas. Is that true? Is there any basis for being concerned about that anymore, or what's the deal?
Well, this is Ann. So from my perspective, diabetes burns out the pancreas, and all the treatments that we have except for the TZDs have been shown to be associated with progressive disease. So if you use metformin, if you use a sulfonylurea agent, if you use insulin, patients get worse over time. And so sulfonylurea agents may or may not burn it out faster. What worries me about sulfonylurea agents is that they increase insulin secretion, cause hypoglycemia and weight gain. But I think you really need to do things that help patients with lifestyle, weight reduction, et cetera, to help their insulin resistance go down. And I think that the TZDs, and now we have Actos left, at a low dose also help preserve beta cell function.
Yeah, there's some data that some of those other agents, glutazones in particular, may have a little better longevity in terms of how long they can maintain glycemic control, but it's not clear that's because sulfonylureas are quote-unquote burning out. That wouldn't be a hesitation I'd have in using a sulfonylurea in an otherwise appropriate patient.
I do think the durability of pioglitazone is a valuable thing to be aware of, and probably is worth some commentary.
Thanks so much, Drs. Nissen, Peters, and Williams, for helping us refine those recommendations about the management of hyperglycemia.